Welcome. I'm Tequila Davina from everydayhealth.com. This is episode 3 of our 4-part series on racism in healthcare, brought to you by Everyday Health, the leading online consumer health and wellness resource. WFAE Public Radio in Charlotte, North Carolina, and ClearHealthCosts, an organization that offers transparency around health costs. In this series of dialogues with experts and advocates, we've been unpacking how structural and institutional racism has shaped US healthcare and has dictated who receives what kind of care. Our healthcare system does not provide equal care to all, worsening health disparities baked into the system over centuries. It is, we have sadly seen with COVID-19 infecting Black and Brown people at a higher rate than white populations, a matter of life and death. Most important in this series, we're identifying solutions that will put the country on a path to finally fix what's gone wrong. Leading these discussions is our host for this series, Mary C. Curtis. Mary is a columnist at Roll Call and a host of the CQ Roll Call podcast, Equal Time with Mary C. Curtis, which examines policy and politics through the lens of social justice. A senior facilitator with the Op-Ed Project, Mary has contributed to NPR, The Washington Post, and The Root, and has worked at the New York Times, the Charlotte Observer, and the Baltimore Sun. A Nieman Fellow at Harvard University, Mary has received awards from the Association for Women in Communications and the National Association of Black Journalists. We want you to be part of this conversation, so be sure to add your questions in the Q&A, and we'll get to as many as we can. Take it away, Mary.
Thank you so much, Tequila, for that wonderful introduction and for setting up today's conversation so well. It's really great because we all know the problem, but what we do in these conversations, we put names and faces on the crisis, highlighting the experiences, challenges, and the actions of those who have been doing the work that benefits so many. And today we have someone who is our guest who certainly has been doing just that. Our guest for today is Dr. Priscilla Pemu, and Dr. Pemu trains medical students and new medical doctors in the specialty of internal medicine. In her research, which is informed by her daily experiences with patient care, she investigates the best ways to improve the long-term health of her patients who live with chronic illnesses. As part of a team at the Morehouse School of Medicine, she developed a system and a method for chronic illness care that empowers patients to change their healthy behaviors through improved knowledge and support for goal setting and accountability in sustaining that behavioral change. Her work brings attention to the impact of behavior on health and well-being among people living with illnesses such as diabetes, as well as the behaviors and practices of the doctors and caregivers who do care for them. She talks about how to empower patients, their families, and their communities. And that's not so much by cataloging and documenting the instances where bad things have happened in the African American and other marginalized communities, which we know happens, but rather by giving, as Tequila said, solutions so people can know better how to engage with tools and resources. And all that is based on her research. She has delivered a widely shared TED Talk, and you'll be happy to know that we do provide a link. So welcome, Dr. Pemu, for our discussion today.
Thank you very much, Mary. I appreciate this opportunity to talk and to share our thoughts about what we've been noticing and doing over the last few years.
Oh, no, that's great. Now, we had a previous conversation when we were talking about this, and you said, which caught my ear, that practicing medicine and managing chronic illnesses and diseases, it means more than filling a prescription. So how so? Could you delve in that a little bit?
And this became even more obvious to me when taking care of people who have a chronic illness. So it's not something that's here and it's episodic like a cold. This is more something where you have to learn to understand what's going on with your body. You have to get some knowledge around what that means. You have to understand the possibilities relative to the medications that you take, because you can get complications, you can get side effects. What we tend to see happen every day is people talk to their friends. They talk to people around them. And the people around them may not have enough information, but people are making decisions based on that. No, don't take this medicine. No, don't do this. It's happened to me like this before. So I very quickly learned that it was beyond just giving someone a prescription. You had to engage with them to understand what their understanding was. Because the other thing that I noticed is we may use the same words when we're talking to each other and describing events and things that are happening, but we may have very different understandings of what those words mean. So when you're engaging with a patient or a person living with a chronic illness, making sure that you actually understand what they're experiencing, what they're understanding about their health condition, so that when you're making recommendations, they actually are getting the kind of information and knowledge that you want to put across.
Yeah, sounds like a lot of people are out there practicing medicine without a license.
Well, it's a very social thing. We're humans, right? We talk to the people that's in our circles, and if someone's had an experience, they may make a conclusion or gain an insight from that experience that may or may not be accurate, but it's their experience, and so they will share that experience across people within their network.
Yeah. So what are some of the barriers to effective treatment, and what's the best way to overcome them, both on the part of the patient and the medical practitioner?
Okay, that's a really big question.
Break it down for us, Dr.
I'm gonna just give a wide view, and then I'll come down into the interpersonal, which is where a lot of my work is. So on a larger scale, obviously, there are things that everyone kind of understands relative to access, for instance. If you don't have insurance, or if your insurance doesn't allow you to do certain things, or your own particular social circumstances. So you've heard conversations around the social determinants of health and how that affects the choices that people make relative to their healthcare. I was listening to the conversation that you had with, I think a week ago, about what this looked like for a Black woman who's making decisions about whether to go in to be hospitalized or not based on her economic circumstances. So there are those larger macro determinants. And then there are the things that happen between you and the person that you encounter, all the way from registration, walking into the healthcare system, to when you get to the actual healthcare provider. When I did a lot of outpatient medicine, I used to get a lot of feedback from some of my patients where they would say, you know what, Dr. Pemu, it's okay when I come in front of you, but it's a huge problem going through all of the hurdles before I get to you. So all those things matter. Those are all problems. But obviously there can be problems with the interpersonal as well. From the patient's perspective or the person living with chronic disease, I'll say always write down what's going on with you, write down your symptoms so you don't forget when you're in that encounter, and recognize it's like everything else in life. You're not going to have the best encounter every time, but know that you are the CEO of your own health. You have knowledge about yourself that nobody else has. And the information that you know about what's going on in your body is really important and relevant to coming up with a full understanding of what's going on with you, which is what would then go into making, one, a diagnosis, and two, a treatment plan. From the healthcare provider perspective, what I've stressed to our colleagues or students and everyone is, every time that you're in front of someone, recognize what the pressure is as that person approaches the healthcare system. You may be busy, you may be rushed, but for that person, that particular individual, it's a big deal. They might be going through any number of challenges. And so come into that conversation with a very humanist perspective. Listen with a heart to understand where the person is coming from and try to meet them where they are to bring them to where they need to be. We have a lot of conversations around empathy and just listening to people. I noticed that we're rushed, we're pressured for time, and sometimes that has an impact on how we're able to listen to people. People can pick up on our nonverbal cues. They can pick up on our body language. And based on that, they might hold back, be reticent about sharing. Or if we're speaking in a completely foreign frame, we're talking about things in a way that's not personal, or terms that we use that we may think are normal or clinical, but that person is reacting to without maybe saying anything. We have to be very cognizant of that. I don't know if that's helpful.
Oh, no, that's exactly. In fact, it leads into one thing you are known for, your own theory and practice of what you call culturally congruent coaching. And you've done the widely seen TED Talk on that. So talk a little bit about what that looks like in practice. And since you did bring up the topic of how racism and racial inequities and structural racism play into these barriers and this lack of communication or sometimes trust between patient and caregiver. So
I'll give you a little background. Thank you for that question. We did a set of experiments. And this particular one was where we had coaches who were not healthcare people. They were just church members, right? People who were retired teachers, retired from civil service. We had a man who was retired from the ATF. We had a retired school principal. People who had just worked through life and they knew how to relate to people. And we trained them with tools developed by the American Association of Diabetes Educators for people at the point of care. Very quick, brief training on what to do with certain numbers when you're meeting with people who are diabetic. And then we train them on the use of our technology, which is Health 360X, which the core of what it provided to those patients in that study was the curriculum around diabetes and what goes on in your body, the same kind of information that I saw in Everyday Health when I went to look earlier, as well as information around goal setting, figuring out your health self-management behaviors, how to work on your goals and things like that. So we trained those coaches and they worked with their church members. And at the end of 6 months, we were measuring what their A1C is, what their blood glucose numbers look like, how well they were exercising. And one of the things, we also conducted the same experiment in doctors' clinics, doctors' practices, where the health coaches were medical assistants that we trained in the same way. Notice that the people in the doctor's office had the doctor in the loop. And at the end of 6 months, we looked at their results. And one of the things that jumped out right away was that the people in the church, even though there was no doctor in the short, immediate loop, were doing just as well, numbers-wise. And then with the ability to stick to the plans that were made to continue on with the plans that were made for behavior change, the people in the church were exceeding.
wow.
And we looked into this, and one of the things we found, we looked at it in several different ways. One of the things that we did, the work that I did when I went to TED was looking into the conversations, because we recorded the conversations that happened between the health coaches and the people who were living with diabetes. And one of the things that was very obvious from just looking at that data was that the coaches from the church had a lot more understanding of the particular context of the individual. So for instance, I gave the example of Ms. Bertha, which is a composite of several of our participants who had certain challenges, but the coach had resources at her disposal. Number one, she had that ability to have Ms. Bertha share what was going on with her. We had people who had visited a doctor several times who were visiting with the health coach, who maybe after 2 or 3 visits then talked about, I can't read, or, you know, can you show me a different way to understand this material? So they felt comfortable enough to show their vulnerability. I don't think that in a setting where it's formal or they feel like they can't be as open, that they would have done that. So for me, I felt that the ability to communicate in a way that gets the person to feel comfortable, that shows that that person gets you in your cultural context. They're not making a judgment of you, right? They know how to see you. They actually see you, not some statistic or some rubric. They actually see the person in front of them, and they're able to engage in an empathetic way to have a real conversation. Then that person can share things that they ordinarily wouldn't share, that may be the major roadblock to them moving forward with their health. And usually when that happens, they're in flow. Then they're having real conversations. When those conversations happen, then you can benefit from the knowledge and the skill of the provider who's dealing with you. And then you're able to engage better because you're seeing results and you're able to meet your health goals. Versus when you feel like they don't even know what's going on with me. They don't understand. So if I'm giving you advice and you feel like I don't understand what's going on with you, you're only gonna go with it for so long. And then if things don't work out the way you expect, you're quick to drop off. Or you're quick to chat with that neighbor who's gonna give you some advice that may not be right. So you get the whole concept, what we're looking at. So you need to establish that. And sometimes it's easier when you share a cultural context, but I don't think that that's a requirement. We're all human. I think that people recognize when people actually see them and are engaging them from a place of empathy and understanding versus from a place of judgment or distance. Now in healthcare, we do have evidence. There's research that's been documented over the years. There was a study in 1999 by Dr. Schulman at Duke that showed that if you were a person of color, if you were a woman, if you were older, you were less likely to get the best kind of care. And that came from just the distance and the lack of engagement between the provider and the person seeking care. So in culturally congruent coaching, when we're training the coaches with these skills, what we emphasize is how to engage, how to come from, so you can have a whole lot of knowledge, but if you're not able to engage in a way that allows the person to trust you, then you're not going anywhere.
Yeah, no, that brings us back to your point about body language. If you're there to see the doctor and you can tell this person is so busy that he or she does not have time for you, you're not going to open up. So it's
no.
I mean, how does that work into your teaching and training of medical students and new doctors? How do you bring that lesson into folks who, of course, they know they have to learn that medicine, but they may not be thinking about how to be as effective as they could be?
So actually what I've seen with, obviously we're at Morehouse School of Medicine where we're very focused on leading the creation and advancement of health equity. So for our trainees, I always see a huge difference, right? They understand about how to engage people, social determinants. They might come in, they're hot shots, they got all the scores and everything. And then you have to learn how to talk to people, how to engage people, how to get people tell you their most, the things that make them feel the most vulnerable, right? So apart from having conversations, giving them practical experiences, trying out these things for our resident Grady Memorial.
We've had a little bit of a tech connection. We're working on that right now.
Can you hear me?
Yes, I can hear you perfectly.
Oh, I apologize. I don't.
No, that's okay. We don't get to see your beautiful face, but everyone has seen that. Yeah, you were talking about the training.
Okay. I am not sure where I dropped off.
But we're talking about the doctors come in and they are hot shots and they have all that information, and then they have to learn this other piece of it.
Thank you for that cue.
Yeah.
So they get a lot of practical experience, practical opportunities where they're communicating with folks other than like the theoretical aspects. And then when they come to clinic, obviously, there's a lot of that as well, where they're watching the residents model it. And so they're able to do it. And for the residents, they see us, the attending physicians, model the behaviors as we communicate in clinic, in the on inpatient service, wherever we're engaging with patients and their families. We have that task of constantly modeling how to engage, how to communicate. And for the residents, they actually get specific competencies around communication with families. So you get to actually, so because it's being evaluated, there is a desire by the residents to get better at it. Other than that, you know, we have conversations where we share specifics around when things go well and when things don't, how to deal with it, when you have difficult conversations with patients and families, how that goes, you know, having conversations around how to manage those, so people understand that in the end, from the healthcare provider's perspective, there's a requirement for you to come from a place of empathy and understanding, but you also want to understand what you're bringing into the conversation that may be affecting how people are engaging, and recognize that even when an encounter doesn't go well, you can't take it personally. And this applies on both sides. You can't take it personally. You have to try to understand what there is to learn from that encounter so that it's different the next go around.
Now, Dakila brought in the intro, he was talking about how COVID and all the stresses that has brought has highlighted some of the inequities that were already baked into the system in so many ways, from who gets care, insurance, as you mentioned, and other things. Has this pandemic, which has put strain on hospitals and doctors and nurses and care providers, has it made that approach more difficult to implement, or has it highlighted the need for it to communicate better? So could you delve into that a little bit? Because right now is a time like no other.
You're right. So for years, we have been beating this drum about the need for health equity. And I remember in the 90s, there were people who would argue, you know, what do you mean? We all treat people the same, you know, we treat, what do you mean? You had to justify it. I don't know if you heard about the study that I shared, the study that was published by this doctor who was at Duke, where they actually did a whole experiment at a doctor's meeting where different actors, they had actors who were women, actors who were older, actors who were men, who were Caucasian versus other people of color. And they went in with the same story and they saw different doctors. And depending on whether you were a woman, you were a person of color, or you were older, you tended to get different recommendations. And so there was proof provided, but constantly there was that need to continue to highlight that there was a problem and that we needed to do something about it. I think with the COVID epidemic or the pandemic, what has happened is it's a little easier to make the case that there is a problem. So now the task for us is the work that needs to be done to change it. You can't, I use the example of you can't put old wine in new skins, right? There has been a way of doing this that people consider efficient, right? That the insurance companies will pay for, but may not get you there, may not get you to the outcome that we're looking for. So if you look at this idea of coaching to support people who have chronic illnesses to get better, there is an advantage for the individual. But I think that what we've seen with insurance and what insurance is willing to pay for is, well, it's not an acute illness right now, we're not interested, right? So no one's necessarily paying for that. There's been some movement with some of the mandates with affordable healthcare to pay for overall improvement in the population of patients that you take care of. So the whole idea about value-based care or population health management. So paying for the overall improvements in the population. But what has happened with that, because of the way the rules are written, is instead of providing resources to take care of everybody, what tends to happen is it's not done that way. So the health systems or health providers will cherry pick people who are not that ill so that their numbers don't, their numbers are not bad, so they're not dinged. So obviously there are systems that tend to take care of people who everyone else may shy away from. I'm very proud that at Morehouse School of Medicine, that is something we run toward. We don't run away from it. There are others. So the hospital where we work, primarily Grady Health System, does that and does that very well. Federally qualified health centers, depending on which one. So in Atlanta, we have a group that's participating in the accountable care organization called the Morehouse Choice Accountable Care. So it's several federally qualified health centers across the state of Georgia that's taking care of people who would otherwise, look like too much of a risk for most healthcare systems, where it requires a lot more investment in additional resources, people who will talk to you on the phone, people who will engage with the participants, who have the skills. And to have those kinds of people and to have them available to support people, they have to be paid. And so it comes down, unfortunately, to what will the system pay for? I think that one opportunity here and now, while we're talking about this, is expanding the concept of what gets paid for. So people who are healthy, right, or people who have resources, maybe can pay for well-being on their own. You're going to the gym and you're doing different things. But rather than wait for people to get to the place where they're needing to be hospitalized multiple times, they're needing to go for additional support after hospitalization, which is very expensive, but the system will pay for that, but won't pay for the steps in between being completely well and being that sick.
Yes.
In a way that's comprehensive. I think there's an opportunity for that, to provide those
We've all
resources.
seen those folks who don't go to the doctor because they can't pay for it, and they end up not going until they're very, very sick.
That's right.
And
And
that's
some of why they don't go,
yes.
it's different reasons. Some
Yes.
people don't go because they think it's going to be an unpleasant experience. I'm going to get yelled at. I may not get what I need. I'm going to get turned around. They're going to find 12 different things wrong when I'm over here talking about this one thing. Or they don't go because they have insurance, or maybe their insurance is one where they have to come out of pocket a significant amount. And so they have to make a decision. Is this something that I can do right now? Or can I keep going? It's almost like that flashing light on your dashboard where you decide, okay, the car's still moving.
Yeah.
Let me.
You don't want to wait till you're sitting there on the
this other
side of
thing.
the road, right?
What was that?
Our listeners and viewers that if they have any questions for you, for Dr. Pemu, to put them in the Q&A and we will present them to her. I wanted to ask you, we've seen some of the challenges and you're working on it. What is it that gives you hope that things are getting better?
What gives me hope? Those times when you have the interactions with people and you see people coming in to seek care and they're coming equipped, right? They come with a little notebook, or there's an older family member who's coming in and may not have quite as much wherewithal to ask the questions they need to have, but they have their other supportive family member or person in their network who comes or is able to call in to ask the right questions, to say things that need to be said in that encounter to move the care forward. That gives me hope. The ability for people nowadays, when we started this, it used to be people didn't even know the medications they were on, right? Couldn't tell you when they came to an emergency room or came to see a doctor exactly what they were on. This was around the time Katrina happened. And now people have access to their patient portals on their phones. So they can pull up and show you everything they're on. So there's some continuity. You're able to then take reliable information and act on it. What gives me hope when I talk with a lot of our young doctors and other care providers, people are activated. People are more willing to go outside of, oh, I'm just going to give you this prescription and that's going to solve the problem. People understand that it is the whole person. Sometimes it's the fact that you didn't get to sleep. Sometimes it's the fact that you do shift work, or you're eating at odd times, or, it's a variety of things. So, there's an increasing awareness, having resources on the internet that people can go to and find what's important for them, that guides them, having good resources that are reliable, not trying to sell anything. That gives me hope. Before I forget, I want to plug medlineplus.gov. Okay, if you're looking for
repeat it one more time.
medlineplus.gov.
Okay.
Government website, part of the National Library of Medicine, and there's all different kinds of health conditions, and there's general information to help you gain some information and knowledge. And sometimes they link you to reputable advocacy groups. So if you have a particular condition and there's an advocacy group that has a good reputation for actually helping people rather than exploit them, you get linkages to those as well. So all those different things give me hope.
Oh, that's great. Any other points you want? I really like that point about taking someone with you. So it's not just the patient and the doctor, but it's a family issue. If the community is involved, it's more than the one person.
Absolutely, absolutely. So if you have, so with the lockdown, one of the additional things that we shared with people was there are resources where you can actually join the person in the visit remotely, right? You can call in, you can video in, and now people can actually do video visits. So you can be in the conversation while they're having the visit with the healthcare provider. There's something that you should pay attention to after every visit, and this was built into the Affordable Care Act. There's something known as a continuity of care document, or an after visit summary. You know that the sheaf of papers that get printed out and handed to you, there's a reason that that happens. The reason that that's given to you at the end of every visit is there's some evidence after much research that a lot of the conversation that goes on when you're in the doctor's office or in front of a care provider, up to 70% of it gets forgotten.
Yeah.
And so that sheaf of papers has the critically relevant information that you're supposed to have. So in addition to what gets posted on your patient portal, that sheaf of information is very important for you to go back and look at, to remind yourself of the different things that you agreed on with your care provider when they were taking care of you.
Wow. Doctor is dropping some truly significant wisdom on us today. That's for sure. I hope you're taking notes on these tips, though we'll have some links for you. Before we wrap up, any other essential things that I did not ask that you wanted to be sure to mention today?
So two things. We're doing a lot of work now training health coaches. We recently got in with the American College of Rheumatology that has a big interest in helping people who are living with systemic lupus erythematosus, lupus, which is another condition that affects people of color way more than everyone else, people living with lupus nephritis. So we're working to develop coaching modules for people who are interested in serving as health coaches, so that they can support the members of their community. And it's also, if you look at a lot of the information out there about health coaching, it's a new way of making a living that a lot of people are going into. So we're making those coaching modules available that's based on this concept of getting to a place of culturally congruent communication and coaching, so that people can be more effective in helping empower people. I firmly believe, and this is what the research shows, that the person who's empowered to care for themselves is the best kind of patient. They do better, they have the best outcomes. So giving people as many tools as possible. And one of them is this idea of training people within the community to serve as coaches, so that they can be effective in supporting the wellness journey for the different people that they know in their communities. You can look for information about this, PriscillaPemuMD.com. We'll post when the trainings are going to be live, or health360x.com. and just leave a note. And as the trainings are ready and rolled out, we will share that information with you.
Great. So I want to thank you again for joining us, Dr. Priscilla Pemu. And she did mention quite a few, her TED Talk and these links to the coaching opportunities in a time where people are struggling economically. As she said, this is another new healthcare field. Very exciting. I want to thank you, and you can read more about this on a page devoted to the series. And thank you again, Dr. Pemu. I've learned a lot, and I'm sure our listeners and viewers have. We're all paying a lot more attention into taking our own health into our own hands. So thank you for that. So for the close, I'd like to turn it back over to you, Daquila.
So on behalf of Everyday Health, WFAE Public Radio, and ClearHealthCosts, thank you for joining today's conversation. Please be sure to join us next week as we talk to Dr. Joya Creer-Perry, the founder and president of the National Birth Equity Collaborative, a thought leader around racism as a root cause of health inequities. Visit clearhealthcosts.com/racism and wfae.org/race and healthcare for more information on the Racism in Healthcare series, and for more on the impact of racism on managing overall health and well-being and chronic health conditions, visit everydayhealth.com. See you next week. Thank you and have a good day.